It's a great pleasure to be speaking to you again for the Bangkok Symposium. I remember being in Bangkok 2 years ago, just as the SARS-CoV-2 pandemic was beginning, and wish I could be back in person. Today, I'll be speaking to you about an update on COVID-19 variants, treatment, and prevention. These are my disclosures. This slide shows an outline of my talk. I'll speak briefly about SARS-CoV-2 variants and their impact on treatment. I'll then spend most of my time talking about COVID-19 treatment for inpatients and outpatients, and say a few words at the end about COVID prevention by PEP and PrEP. Since Professor Kiat has spoken about vaccines, I'll really be talking about other pharmaceutical approaches to COVID-19 prevention. This slide shows the situation as it evolved over time in the United States and Massachusetts, showing that at the beginning of 2021, we saw a gradual decline in the original variant that was circulating the world and an uptick in the Alpha variant, which was then a variant of concern. There was a brief increase in the numbers of gamma and iota and beta viruses, but these were then very rapidly overtaken by Delta in the late spring, early summer. And so that Delta had become predominant by the summer of 2021. However, the situation changed again equally rapidly at the very end of last year as Omicron came to dominate not only in the United States, but throughout the world. If we look at the phylogeny of these different variants, we can see that they've actually all arisen from primordial strains sharing most recent common ancestors. It's not as though Alpha evolved into Beta and into Delta and into Omicron, but you can see how they stretch back really to a much older strain, so that these represent completely novel generations of variants that then have the capacity to take over and become dominant because of advantages in transmissibility. Characteristics of the Omicron variant that make it concerning are that it has 30 mutations in the spike protein, resulting in its being highly transmissible. However, an increasing body of data suggests that Omicron is also likely to be less virulent. However, it is less susceptible to neutralization by vaccine-induced antibodies, and it is resistant to neutralization by many of the currently approved or authorized monoclonal antibodies, as I'll note later towards the end of my talk. Fortunately, all the data suggests that Omicron remains susceptible to RNA-dependent RNA polymerase inhibitors and to the major coronavirus protease inhibitor, as we'll see. Well, let's start by talking about COVID-19 therapeutics. Instead of going through a long list of the different drugs that have been either shown to be effective or have been authorized or approved for treatment, I'm going to break this talk down into two parts. Treatment for inpatients, those with moderate, severe, or critical disease resulting in hospitalization for COVID-19, using antivirals or immunomodulators, and treatment for outpatients, those with mild to moderate disease who don't require hospitalization, but where treatment might prevent progression to the point of requiring hospitalization or progressing to severe disease and death. And here there are a number of small molecule antivirals, as well as monoclonal antibodies, which are, of course, also antivirals since they prevent virus entry. Well, let's start by talking about treatment of patients with moderate, severe, or critical COVID-19. In these patients, there are three categories of drugs that have been shown to be effective. These include corticosteroids, principally dexamethasone, small molecule antivirals, and here it's really remdesivir, and then other immunomodulators, including kinase inhibitors, baricitinib, and also tocilizumab, and then IL-6 receptor antagonists, tocilizumab and sarilumab. Let's start by talking about corticosteroids, which were the first drugs to be shown to be life-saving. The recovery trial demonstrated the effect of dexamethasone on 28-day mortality based on the level of respiratory support at study entry. This was a large randomized trial with over 11,000 participants, And the study showed that for those who were already receiving supplemental oxygen or receiving invasive mechanical ventilation, there was a substantial and highly statistically significant survival advantage to being treated with dexamethasone, as you can see shown here and here. However, for those who were not yet receiving oxygen, there might actually have been harm from the use of systemic corticosteroids. This did not achieve statistical significance, but clearly the direction of the effect is suggesting that standard of care was better than use of dexamethasone. These data led to the adoption by the WHO of guidance on the use of corticosteroids for COVID-19, leading to the recommendation that systemic corticosteroids should be used in people with severe or critical COVID-19, and this is considered a strong recommendation. It was also recommended that systemic corticosteroids not be used in patients with non-severe COVID-19, that is, those not yet requiring supplemental oxygen. And the evidence was based on the data showing a moderate certainty of evidence of mortality reduction between 7 and 9% in patients with COVID-19 who were critically or severely ill and received corticosteroids. And the key practical issue is that the dose would be 6 milligrams daily of oral dexamethasone or 50 milligrams intravenously every 8 hours of hydrocortisone for 7 to 10 days. What about antivirals? Well, remdesivir has been studied in a variety of settings in patients in the hospital with COVID-19. The first study to show a benefit was the ACT-1 study, a placebo-controlled, double-blind, randomized controlled trial in hospitalized adults with COVID-19 pneumonia who were randomized evenly to remdesivir or placebo with a primary endpoint of time to recovery within 28 days. And it's important to note that the primary endpoint is not mortality, but it's time to recovery. What you can see is overall, remdesivir showed a benefit with faster time to recovery among recipients compared to placebo, but that benefit was seen principally in those receiving supplemental oxygen. There was a less evident benefit, not statistically significant, in those who were not receiving oxygen, and there was no benefit among those who were receiving high flow oxygen and other non-invasive mechanical ventilation approaches, or in those already ventilated or on ECMO. Now, by contrast, the Solidarity study, which was a very large randomized trial with various arms, showed that when remdesivir was compared to control, there was no difference whatsoever. But here, the endpoint is in-hospital mortality. So a very different endpoint than the endpoint studied in the ACT-1 trial. And it's important to bear that in mind. Subsequently, a post hoc analysis or retrospective analysis of a large cohort of patients in multiple hospitals across the United States using propensity weighted adjustment for risk factors showed that the use of remdesivir in participants or patients not receiving oxygen, those receiving low flow oxygen or high flow oxygen, all of them hospitalized, led to substantial and statistically significant reductions in 28-day mortality. Here, 14-day and then 28-day mortality. The one group not convincingly showing benefit are those who were already receiving high flow oxygen. However, this was a cohort study, not a randomized trial, and therefore needs to be taken in context. So as a summary for remdesivir, currently US guidelines recommend the use of remdesivir in combination with dexamethasone in hospitalized patients requiring supplemental oxygen, but the use of remdesivir currently is not endorsed by the WHO. But what about other immunomodulator therapy? ACT-2 was a study of the kinase inhibitor baricitinib in combination with remdesivir. Here in this randomized double-blind placebo-controlled active controlled trial in adults with COVID-19 pneumonia and hypoxia, participants were randomized to receive either remdesivir or remdesivir plus baricitinib, again with a primary endpoint of time to recovery within 28 days. So not a mortality endpoint, but a recovery endpoint. Overall, there was a modest but statistically significant benefit of adding baricitinib to remdesivir. This difference became most apparent in participants who had an ordinal score of 6. This was on an 8-step score of people where 1 was best and 8 was worst. And you can see in this narrow group of people, there was a substantial difference, and these represent those who were requiring high flow oxygen or really on the cusp of requiring invasive mechanical ventilation, whereas those who were already on mechanical ventilation showed no benefit when baricitinib was added to remdesivir. Tofacitinib is another kinase inhibitor that was studied in the Stop COVID trial. Here, the primary endpoint was the cumulative incidence of death or progression to respiratory failure. And what you can see is that the use of tofacitinib resulted in a statistically significant reduction in the risk of progression, about a 35% reduction. That was true in both men and women, more so in those who were older than younger. Also more so in those who were not receiving concomitant antiviral therapy, as it seemed to have a better effect in those who were also receiving glucocorticoids and in those who were treated earlier rather than later. Now, the REMAP-CAP study explored the use of IL-6 receptor antagonists, tocilizumab and sarilumab, as well as the use of anakinra as compared to standard of care. This was part of a large multi-arm platform trial, and these data come from the immune modulation domain of that trial. Initial results had been reported earlier in 2021 based solely on the results from tocilizumab. At that time, very few participants had been on sarilumab, although the results were concordant. These data that I'm showing here are the final results of the study after it was fully enrolled, with nearly 1,000 participants receiving tocilizumab, just under 500 receiving sarilumab, and about 370 on anakinra and 400 on standard of care. The primary endpoint here was days alive or free of ICU-based support through day 21. And this study used Bayesian statistics looking for superiority or futility. And what the study showed is that tocilizumab and sarilumab had a very high probability of being superior, greater than 99% probability of being superior to standard of care, whereas anakinra failed to meet that benchmark. And there was also a good probability, 85%, that tocilizumab and sarilumab were equivalent. This slide shows the cumulative proportion of patients having organ support free days. This is not really a Kaplan-Meier plot of progression, but shows the cumulative probability. So at the end, you're at 100%. And what you can see is that the number of organ support free days is greatest in these upper lines, the red and blue lines, for participants who received tocilizumab and sarilumab versus those who received anakinra or control, also shown here in the plot at the bottom. So to summarize the treatment for patients requiring hospitalization, these guidelines come from the NIH treatment guidelines for patients hospitalized with COVID-19. Those requiring supplemental oxygen, those not requiring supplemental oxygen but hospitalized, really there's insufficient evidence to recommend either for or against the use of remdesivir, but they should not receive corticosteroids. Those who do require supplemental oxygen should receive both remdesivir and dexamethasone. And those who have progressed to require high flow oxygen should again be receiving dexamethasone, ideally with remdesivir, and one might consider the addition of either baricitinib or tocilizumab. And one could use sarilumab if tocilizumab is unavailable, and you could use tofacitinib if baricitinib is unavailable. Once patients have progressed to require mechanical ventilation or ECMO, there's much less evidence that at that point remdesivir can have any benefit. So those patients should receive dexamethasone with intravenous tocilizumab, and again, using sarilumab if tocilizumab is unavailable. WHO guidelines are similar, although they have a difference largely with respect to the use of remdesivir. There's a strong recommendation for the use of systemic corticosteroids in patients with severe and critical COVID-19. A conditional recommendation against using remdesivir in hospitalized patients with COVID-19, and a strong recommendation to use IL-6 receptor blockers, either tocilizumab or sarilumab, in patients with severe or critical COVID-19. WHO is silent on the use of the kinase inhibitors, baricitinib or tofacitinib. Universally not recommended are hydroxychloroquine, ivermectin, azithromycin, or lopinavir-ritonavir, each of which has been shown to be ineffective in the treatment of COVID-19. Well, what about treatment of patients with mild to moderate COVID-19? Here, there's been much progress made, especially in the last 6 months, and this includes evidence for the efficacy of small molecule antivirals, including the protease inhibitor nirmatrelvir, which is given in combination with ritonavir, remdesivir in the use in outpatients, the novel use of that drug, and molnupiravir. In addition, monoclonal antibodies can be effective in preventing disease progression, although this is a constantly changing area because of the evolving nature of the different COVID-19 variants. So let's start with a discussion of nirmatrelvir and ritonavir. Nirmatrelvir is a SARS-CoV-2 3CL protease inhibitor, sometimes called the major coronavirus protease, so it's also known as an MCP inhibitor. It's administered twice daily with 100 milligrams of ritonavir. The EPIC-HR trial was a phase 3 study of this combination that it sought to enroll 3,000 participants from around the world, with a primary analysis after just over 1,200 participants had been enrolled at the end of September 2021. That scheduled interim analysis showed a nearly 90% reduction in the risk of COVID-19 related hospitalization or death from any cause compared to placebo and those treated within 3 days of diagnosis, and that was highly statistically significant, with similar results in those treated within 5 days of diagnosis, again, highly significant. There were no deaths in the nirmatrelvir-ritonavir arm, as opposed to 10 deaths in the placebo arm. A similar study was done with remdesivir in the outpatient setting, in which participants received either remdesivir given for 3 consecutive days intravenously versus placebo. This study, called the Pine Tree study, looked at hospitalization or all-cause mortality by day 28. And you can see that those who received remdesivir were at substantially lower risk, approximately 87% reduction in the risk of progressing to hospitalization or death as compared to placebo. There were, in fact, no deaths in either group, so this is really just looking at reduction in hospitalizations. These were all people with symptomatic COVID-19, and I should note that in all of these trials, the studies limited enrollment to participants at high risk of disease progression, so those with medical comorbidities that place them at greater risk for severe COVID-19 or being older. Molnupiravir falls into a somewhat different category. This is a nucleoside analog that is a prodrug. It's a cytidine analog. It competes with cytosine triphosphate for incorporation into RNA. The proposed mechanism of action is inhibition of SARS-CoV-2 by causing the accumulation of errors during viral replication that lead to what's called error catastrophes. So many misincorporations occur that the resulting viral genetic material is unable to direct production of infectious viruses. There's some debate as to whether this is the true mechanism of action or whether this is merely an RNA-dependent RNA polymerase inhibitor. But it is mutagenic and teratogenic, and as a consequence, this drug is not recommended for use in pregnancy and must be used with caution in women of reproductive potential. The Move Out study was a phase 3 trial designed to look at the efficacy of molnupiravir in preventing disease progression, much as the EPIC study with nirmatrelvir and the Pine Tree study with remdesivir. But here the results are somewhat confusing. The initial analysis, which was an interim analysis when the study had hit the predefined benchmarks, showed a 50% reduction in the risk of disease progression, as shown in the left in this slide. However, when the study enrollment to the study was stopped, it had enrolled almost in the entire intended cohort. And so when the final analysis was done of all the enrolled participants, the magnitude of the benefit was actually much smaller, largely because of a reduction in the event rate in the placebo group. So the final result is about a 30% reduction in the risk of disease progression, a much more modest benefit than seen for either nirmatrelvir or for remdesivir. Monoclonal antibodies have also been shown to be effective in preventing disease progression. The initial studies were done with the combinations of bamlanivimab and etesevimab, as well as with the Regencov combination. But since the changing phylogeny of the predominant variant, now with Omicron being the major variant circulating around the world, those antibodies no longer have efficacy. And so I'll focus on the antibodies that continue to be effective against Omicron. That includes sotrovimab, a human monoclonal isolated from a survivor of SARS-CoV-1 infection. So this is actually an antibody that has cross-reactivity against SARS-CoV-2. It targets a conserved glycan at position 343 in the spike protein. And in the Fc domain has the LS modification that results in prolonged half-life, so that this drug could be dosed once and then have adequate levels for activity for several months thereafter. An attribute more important for prevention than for a treatment of acute infection. The COMET-ICE study was a phase 3 clinical trial that enrolled participants at risk of disease progression. You see the design shown here as published in the New England Journal of Medicine. But I'm actually going to show you data from the updated analysis, which is the full data set. Here, the results did not change from the interim analysis to the full analysis, but I may as well show you the complete data with nearly 1,100 participants enrolled. Here we're looking at the risk of hospitalization or death through day 29. And what you can see is that the adjusted relative risk of progression was 0.2, meaning an 80% reduction in the risk of disease progression for those who received sotrovimab compared to those who received placebo. And that was highly statistically significant. Now, that was with intravenous dosing, but the COMET-TAIL study compared the use of intramuscularly administered sotrovimab to intravenously administered sotrovimab. One of the big limitations in the use of antibodies for the treatment of early COVID-19 is simply the logistics of doing infusion therapy in people with COVID-19 who have to be on respiratory isolation and finding the capacity to deliver this, which even in the United States has proven to be a huge challenge. If one could give intramuscular injections, that would be much easier than having to do a half-hour-long infusion and then observing the patient for some time thereafter. This study demonstrated the non-inferiority of intramuscular administration compared to IV, with progression rates of 2.7 and 1.3%. You can see the adjusted difference was just about 1%, which fell within this very narrow confidence limit, with the upper bound of 4% being the predetermined boundary for establishing non-inferiority. Now, sotrovimab retains activity against the Omicron variant. The EC50 is slightly increased, but not sufficiently increased to render sotrovimab ineffective. Another combination of antibodies that has been shown to be effective in prevention of progression and that are expected to retain activity against Omicron is this two antibody combination, BRII 196-198, that was studied in the ACTIV-2 trial by the AIDS Clinical Trials Group. Again, very similar outpatient population. You can see the progression rates were 11% in the control, just under 2.5% among those who received the antibody, and this was a highly significant result. I should say one word about the use of antibodies in hospitalized patients. By and large, these antibodies have not proven to be effective once people require hospitalization, with the exception of people who have not yet developed antibody responses to SARS-CoV-2. And this is of particular importance for immunocompromised patients who may be incapable of developing an antibody response. You can see here, using the REGEN-CoV combination of antibodies, casirivimab and imdevimab, that among those who were seronegative, there was a significantly lower mortality among those who got the antibody compared to usual care, but there was no difference among those who were already seropositive. Now, even though REGEN-CoV is no longer being used in the US because of the predominance of Omicron, these data have been extrapolated to sotrovimab, which is now being used for hospitalized patients who are seronegative or immunocompromised. So to summarize outpatient treatment recommendations, antivirals and monoclonal antibodies can be effective in preventing disease progression. They must be used early. Limited access is a universal problem, and it's important to prioritize the use of these agents in patients at highest risk of disease progression. Well, let me end by saying just a few brief words on the use of SARS-CoV-2 monoclonal antibodies for post-exposure and pre-exposure prophylaxis. The initial studies that demonstrated that post-exposure prophylaxis with SARS-CoV-2 monoclonals used either bamlanivimab as a single agent or the combination of casirivimab and imdevimab. In the case of bamlanivimab, this was a study done in nursing homes and in residential care facilities where there had been index cases, and then vans went out to implement the trial, and the participants who were residents in these facilities, as well as staff, were treated with either placebo or antibody, and you can see there was a highly significant reduction in the risk of developing symptomatic COVID-19. The casirivimab and imdevimab study was done in household contacts, and again showed a significant reduction in occurrence of symptomatic disease among household contacts of index cases. But of course, these antibodies are no longer being used for this purpose because of the predominance of Omicron. The PROVENT study looked at two novel antibodies, tixagevimab and silgavimab, and showed that these two antibodies, known by their trade name Evusheld, led to a 77% reduction in the occurrence of symptomatic COVID-19 in those who received the antibody compared to those who received placebo. This study was done in people who were unlikely to have responded to the vaccine. Now, the effect of this antibody against Omicron, or this combination of antibody against Omicron, is somewhat mixed. Silgavimab retains reasonable activity, and although there is about a 2-log shift in the EC50, there's enough antibody present at current doses to overcome this modest level of resistance. But tixagevimab is essentially inactive. So the combination remains active largely because of the activity of the silgavimab component. How this will really play out in clinical practice remains to be seen. So in conclusion, antivirals and immunomodulators can reduce mortality from COVID-19 when used appropriately. Early treatment in high-risk patients can prevent disease progression, hospitalization, and death. Pre- and post-exposure prophylaxis with monoclonal antibodies is effective, but only certain mAbs retain activity against Omicron. Treatment and prevention of COVID-19 continues to evolve along with the virus. Thanks so much for your attention.